Good morning, everybody. Thank you, Dr. Pappas, for allowing the opportunity to present at the Fellows Conference here and series. Today, I'll be talking about diagnosis and management of post-thrombotic syndrome. As many of you were part of the excellent journal club this week, there certainly is a lot to be learned outside the superficial venous compartment. And, delving into the pelvic venous system, there's a lot of things that come along with that territory, and one of them being post-thrombotic syndrome. We have all seen patients in our practice that have DVT, and statistically speaking, unfortunately, DVTs occur in approximately 2 million Americans each year, and approximately 1/3 of them develop PE. The combined annual incidence of DVT is still approximately 2.5 to 5% of the adult population. And we know that once we get the patient out of the woods and we treat their DVT, unfortunately, these patients are at an elevated risk for recurrence of DVT. Up to 10% of the patients the year after anticoagulation can develop a DVT. As these patients are followed out 8 years later, statistically speaking, DVTs can recur in up to 30% of these patients. And so, as you can imagine, this is a bigger problem than we think. This is not just something where we anticoagulate a patient and again, treat their quote unquote DVT and then, let them go on their way. These patients do require long-term monitoring, and we'll speak shortly as to why. But unfortunately, DVTs and PEs still remain the most preventable cause of death in the United States of America. And, that's why, again, it's really important to help continue to educate our peers in the communities as we go out and talk to our referring doctors. Risk factors, again, this is all much review for the fellows as well. Age, greater than 40, cancer, we know it's a hypercoagulable state. So prothrombotic, obesity, previous family history of DVT or PE, recent surgery, immobility, hormone replacement therapy, pregnancy increases, causes a prothrombotic state, patients that have other concomitant illnesses such as heart failure, MI, sepsis, and coagulation disorders. So really important when we're evaluating our patients and getting a thorough history and physical to ask these questions and to certainly keep them in mind as we're assessing patients, especially patients that present clinically with calf pain and tenderness. As you can see here on the slide, the patient has certainly a much more swollen right limb versus left. And, these patients can present, as you know, with calf pain, tenderness, swelling, calor, rubor, cyanosis. Sometimes these patients have increase in pressure into their superficial venous compartment and can get superficial venous dilatation. And at its worst, with the swelling that can occur, sometimes it can be difficult to palpate pulses. Why is it important to talk about DVTs? I know this is not a DVT lecture, but I think it's important to, as a segue into talking about post-thrombotic syndrome. DVTs are not going away. In fact, this was published in Journal of Hematology in 2011. The trends in DVT are that it's expected to double in prevalence by 2050. And so really important as our patients are living longer, as advancement in science and medicine, that more patients that have experienced a DVT, both in the present and in the past, will be coming into our offices. So it really bodes us well to make sure we're keeping in mind the long-term sequelae that DVT can have in our patients. Not all patients that come in with limb swelling, as we know, have venous disease or venous outflow obstruction. So that's why it's really important to rule out other factors: heart failure, hypoproteinemia, liver diseases, kidney diseases, cirrhotic diseases, and most importantly, well, not most importantly, but more commonly, medications. I will tell you, a lot of times in our practice, when patients come in with chronic limb swelling, one of the easiest fixes is asking them whether they've had a recent medication switched or added. And typically that can help as well, because as you know, side effects of medications oftentimes are limb swelling. So something just to kind of keep in mind. But focusing on the crux of the talk, iliofemoral venous thrombosis can certainly occur in patients that have had DVT. Why is it important to talk about iliofemoral venous thrombosis? Well, it's important to discuss this because this puts a patient at an elevated risk of post-thrombotic syndrome, and we'll talk about studies shortly. 25% of symptomatic lower extremity DVTs occur in the iliofemoral compartment. And also there's an increase in recurrence of VTE at 2.4 times. So really important in a patient who has a DVT, assess for the compartment of where that DVT lies. Just as a quick anatomical review of the pelvic anatomy, this is courtesy of Dr. Frank Netter to the left here. The point here in this slide is that we know that there's a very intimate connection between the arterial and venous system, particularly in the pelvic compartment. As you can see, there's many crossover points. We know that there's non-thrombotic compression points as well, right? Or non-thrombotic iliac vein lesions that can lead to venous outflow obstruction. But post-thrombotic syndrome actually poses a problem on the inside of the vein due to scarring and narrowing. But my point in the slide here is to show you that areas of compression do not only occur on the left side. There's no such thing as a right-sided May-Thurner syndrome. I've heard that oftentimes. May-Thurner syndrome, by definition, is the left common iliac vein being compressed anteriorly by the right common iliac artery. Yes, you can have compression further down distally on the left side, or multiple compression points, as you can see on the right side as well. But the point here is that those compression points can certainly cause an elevated risk of DVT in patients, oftentimes going undetected. And sometimes years later, these patients present with chronic swelling in their legs. And as we become more astute in our practice, we start to look for pelvic venous outflow obstruction and may find chronic scarring in these areas. Post-thrombotic syndrome can occur in up to 47% of patients that have experienced a blood clot. And these are even patients that we've very adequately treated with anticoagulation. So this is not a knock on any clinician or society. This is just the fact of the disease. So my point here is that no matter how well you treat this patient and how fast you treat this patient, 47% of these patients can go on to develop this chronic scarring. 25 to 33% of these patients will develop severe symptoms such as ulcers and ultimate skin deterioration, as you can see in the slide on the right-hand side. And from a cost-conscientious standpoint, 75% of the cost of treating DVT is actually related to post-thrombotic syndrome. And this can ultimately represent as a permanent disability. So you can imagine how important this is to detect in our practice for ultimate patient safety and quality of care. What about the pathophysiology of post-thrombotic syndrome? Well, again, acute thrombus ultimately can lead to inflammation, and this ultimately can lead to destruction of the valve itself, or the inability of the valve to ultimately coapt, because as the vein starts to dilate and the valves don't coapt, this will then lead to venous reflux, thereby leading to venous hypertension. And so over time, the way I explain it to my patients is that the blood clot is more like it's cement, it's hardening over time. And so you can thin the blood and try to dissolve the clot as much as possible, but 47% of the time, some of that clot will be left behind and become incorporated into the wall of the vein, thereby causing that narrowing to occur and that pressure being translated down the leg into the superficial venous compartment. What about treatment of these patients? How do we approach this? And in that respect, I think it's important to discuss, again, evidence-based medicine. And so CAVIN trial was one of the earlier trials that looked at patients. 209 patients were looked at with DVT. And these DVTs were above the mid-thigh level, and they were stratified and for pelvic involvement. And basically, the two groups were the catheter-directed thrombolysis group with RTPA or alteplase, and the control group was low molecular weight heparin, which these patients were then bridged over to warfarin. And so these two arms were looked at. Again, catheter-directed thrombolysis with TPA versus low molecular weight heparin bridging to warfarin. And the outcomes that were looked at were the frequency of post-thrombotic syndrome and iliofemoral patency after 6 months. And many of us know these results already, but very important to review. The CAVIN trial at 5 years showed that while the patency rates were similar, the incidence of post-thrombotic syndrome in the catheter-directed thrombolysis group was far less. You can see the statistics there. And so That was something that opened up, or raised a lot of eyebrows. So the ACCP guidelines in 2016 mentioned that patients that present with an acute proximal DVT of the leg suggest anticoagulation therapy alone over catheter-directed thrombolysis. But there was an asterisk next to that, and that was that patients who are most likely to benefit from catheter-directed thrombolysis have an iliofemoral DVT, symptoms for less than 14 days with good functional status, life expectancy of more than a year with low bleeding risk. And you may say, well, why iliofemoral DVT? And for that, I want to cite the ATTRACT trial. So the ATTRACT trial very nicely stratified patients with iliofemoral DVTs versus femoral popliteal DVTs. And both subgroups were then broken down into catheter-directed thrombolysis plus anticoagulation versus anticoagulation alone. And when both groups were looked at side by side simultaneously after 24 months, what it was found was that the group that actually really benefits from a decrease in post-thrombotic syndrome, post-catheter-based thrombus removal and anticoagulation is the group that has the thrombus in the iliofemoral segment. The statistics there, as you can see on the screen, showed that the significance of, or the likelihood of having post-thrombotic syndrome was far decreased in the iliofemoral group. The femoral popliteal DVT group did not show much statistical significance when these patients were followed up at 24 months. So yes, there's a decrease in frequency of long-term morbidity of severe PTS in that iliofemoral DVT group, which results in a decrease in potential ulceration, pain, chronic swelling, and heaviness. So what about diagnostic modalities? How do we follow these patients, or how do we even look for this disease process? Well, many of you, again, are familiar with the pelvic transcutaneous ultrasound. That's the least invasive route. That's typically where we start. Obviously, ultrasound is not 100%. It does have its limitations, particularly in the pelvic compartment. We know that there's, adipose tissue there. There's gas that potentially can be limiting us from allowing what we need to see. But we do typically start with that. If that is not helpful, one does have the opportunity or potential to get a CT venogram or MR venogram. I know many of my colleagues at CVR feel very strongly about that and feel that that is an adequate test. And while I don't disagree, I just think that regionally it depends on your local radiologist. I'll be honest with you, the first couple of times I ordered this test, the patient came back with an angiogram. And when I asked the radiologist, I said, why did you do an angiogram? I'd asked for a venogram. They said, this test is so less frequently ordered, we thought you made a mistake. We actually were doing you a favor. So my point here is that if you're going to order this test, make sure you have a communication with your local radiologist that you're sending this patient to, so that they know that ahead of time. Venography is the old gold standard. Venography, as the name suggests, is injecting dye into the veins and getting a view at real time. But the new gold standard is intravascular ultrasound. And so intravascular ultrasound, again, as many of you know, is a three-dimensional view of the vein from the inside. That is a catheter that allows us to visualize and measure the lumen size in real time. It also allows us to get a percentage of luminal compression if there is one. Now, I must warn you, those of you that are planning to do this, post-thrombotic changes do not necessarily give you lumen compression. Why? Because sometimes post-thrombotic changes line the entire lumen of the vessel. And so if you're trying to get a percent narrowing, if the entire thing is narrow, then it's very difficult to get that. So in that scenario, we just call it chronic scarring with post-thrombotic changes. And I'll show you an IVUS image shortly. The other important thing about IVUS is it allows you to visualize any type of webbing or scarring, which may not be evident on venogram alone. In fact, there was a study that was done not too long ago called the VIDIO trial, VIDIO, if you'd like to look it up, if you're not familiar with it, and it compared venography against IVUS. And basically, patients were looked at, and there were 3 views of venography performed on the patient, and the interventionalists then went ahead and documented whether they felt that the patient had iliac vein compression or not. Then these same patients were then taken with an IVUS. And so what was found was almost 28% of patients that underwent IVUS actually had disease that were mentioned with venogram alone not to. So the point here is that one will miss disease if they don't utilize IVUS. Not only will they miss it, but they may missize their stents or may not be able to appreciate sneaky air webbing, which is important for post-thrombotic syndrome. So what does it look like? This is a very nice image, both surgical image and IVUS image to your right. So surgically, you can see those scars, those little bands that are making their way as that vein has been opened up. And you can see that that potential scarring can lead to luminal narrowing, thereby causing difficulty for the vein to clear the blood. And from a three-dimensional view, that arrow is pointing towards the outside of the catheter at about 4 or 5 o'clock. You can see that area of kind of like that hyperechoic area, which is again, an area of scarring. So whenever you see the vein, it's no longer that nice ellipse and there's jagged edges. Sometimes these projections are what this post-thrombotic scarring looks like. So once we diagnose it and we've gotten a thorough history and talked to the patient about the risks and benefits of treatment, what are our options? Well, open bypass was an option, and it's an old option, and open vascular surgery, certainly is helpful in the right patient, but open bypass surgery is invasive and painful, and minimally invasive techniques have evolved significantly over the past 20 years. So minimally invasive is the first line of treatment in patient. And in that vein, stenting has become the preferred therapeutic alternative in patients that have symptomatic post-thrombotic syndrome. As we all know, this can be performed very safely in an outpatient setting with low morbidity and excellent long-term results. The Center for Vascular Medicine has shown very good results, and we are not the only ones that have demonstrated this. This has been certainly something that has been in the literature for many years. Quick discussion or quick talk about compression stockings. Yes, compression stockings are very helpful to alleviate some of the symptoms that potentially occur with DVT. But this study was done and published in Lancet in 2014, actually looked at whether compression stockings prevent post-thrombotic syndrome. And this large multi-center placebo-controlled study found that the routine use of compression stockings actually did not reduce the incidence of post-thrombotic syndrome. So just again, when I first started coming across this, I said, well, why don't we just compress it and maybe we can prevent this patient from getting post-thrombotic syndrome. But this study actually showed that it did not make much of a difference. Now, it's not to say that stocking compression therapy is not important. It is important to help maybe with symptoms, but post-thrombotic syndrome can still occur. Talking about iliac vein stenting. Does iliac vein stenting help? Well, one cannot talk about iliac vein stenting without addressing Dr. Raju and his team with the amount of studies that they have performed. This was one of the earlier studies in Journal of Vascular Surgery published in 2002. And this study looked at the clinical impact of iliac venous stents in the management of chronic venous insufficiency. And their group looked at 304 limbs with iliac vein stents placed in the outpatient setting due to chronic venous insufficiency. Of these patients, 280 of them were C3 and above. And as this study showed, there was significant improvement as these patients were followed over 24 months in 4 major categories: improvement in pain, swelling, stasis and dermatitis, and ulcer healing. And so they went on to conclude that iliac vein stents are effective when utilized in the correct clinical scenario. And I think that's, that goes without saying, but also cannot be said enough, because it has to be utilized in the correct clinical scenario. Stenting in the iliac vein is not the first option. We have to make sure that we, like superficial venous insufficiency, try conservative measures with patients and make sure these are truly lifestyle limiting features prior to inserting a stent. Now, about 11 years later, he then followed up, him and his group followed up with over 1,500 patients. And this was published in Journal of Vascular Surgery in 2013. 1,500 patients were looked at with disabling symptoms and who failed conservative measures. Morbidity, as these patients were followed, was less than 1%. So they looked at patency at this point at 3 years. In non-thrombotic lesions, those typically had extrinsic compression, the patency rates were excellent, 90 to 100%. The post-thrombotic patients, the patients that we're focusing on in this talk, the stent patency at 3 years was 74 to 89%. So still demonstrated excellent patency. Relief of pain, 86 to 94%, relief of swelling, 66 to 89%, and venous ulcer healing rates of 58 to 89%. So again, the numbers looked quite favorable for these patients. But again, these were patients, again, who had disabling symptoms and failed conservative measures. And we should not lose sight of that fact as we're evaluating these patients in our clinic and potentially doing venous stenting in these patients. I'd like to share a quick case with y'all. This is a 68-year-old female who had presented to our clinic, and she had a recurrent left medial ankle ulceration for 6 years. And it wasn't that she wasn't in the hands of good clinicians. She was seen by some very good podiatrists, primary care doctors. She was even sent to wound care, but no matter what was done, the ulceration kept recurring. Unfortunately, she saw a competitive group, and what was happening was this competitive group was continuously performing endovenous ablations as the ulcer would wax and wane. And multiple is an understatement. This patient had over 14 ablations over 2 years. And again, not to throw any competitors under the bus, but again, we at Center for Vein Restoration know better than that. And whenever we have ulcers that recur, we need to look outside the box here. So this patient presented with a past medical history of left leg DVT about 15 years ago, which was quite a while ago. Her pelvic venous duplex was performed. And again, as I mentioned earlier, pelvic venous duplexes are helpful, but sometimes you cannot visualize the CIV secondary to overlying bowel gas. And so this is what the ulceration looked like. This is the left medial ankle. You can see that large crater-like ulceration, and then about 5 o'clock below it, a smaller ulceration forming. It was very painful for her. She was very, very upset about, God bless you. She was very upset about the ulceration. It was painful. She was becoming very conscientious of it. She said she did not want to even go to church anymore because she was worried that people would start looking at her ulcer, or it would smell, or it would drain. And as you can imagine, again, this is something that we deal with our patients. So what did we do? We went ahead and did diagnostic venography. Why? Because a patient who has an ulcer like this, who's had multiple ablations from an outside practice with waxing and waning of the ulceration, we have to think outside the box. And as I mentioned, the patient also had a DVT 15 years ago. And so you may, again, many of our colleagues, our hematology colleagues I have these conversations with, I say, I would like to evaluate your patients that have had a DVT, I don't care how long ago. And they go, why? Because, we've treated these patients. And again, the misconception is that once the patient is treated, that they're completely out of the woods. And this was a prime example of somebody who had a DVT 15 years ago. Look at the venogram here. You see the red circle there. That's the area on the left side. So what you see is you see the dye making its way up the right side and the left side. And imagine looking at the patient from the ceiling down. And you can see a lot of these little collateral branches coming out, these squiggly lines coming out on venography. Those should not be there. So that means that blood is making its way up the left side. It's hitting some resistance, and it's recruiting those collateral veins to get that blood around that area. And that area is actually the left common iliac vein there. What is it? There's the arrow there just kind of showing where the area of interest is. What did it look like on IVUS? Take a look at this. This is the IVUS pullback. And so I don't expect everybody to know exactly what we're looking at, but we're going to let this run. I want you to appreciate the circle in the middle is the IVUS catheter itself. And the area around the IVUS catheter, the dark or the black area around the IVUS catheter is the lumen where blood is. All the white speckling in the periphery is the wall of the vessel. What I'd like for everybody to notice is that on the initial pullback right here, you see a very, very nice ellipse, right? Very nice circular pattern. This is the IVC, the inferior vena cava. And what we're doing is we're pulling the IVUS catheter back from the IVC. And as we're pulling the catheter back from the IVC, it's eventually going to land into the left common iliac vein. And you would expect the left common iliac vein to also be a very nice ellipse. But what you see here is you see a very jagged lumen. You see these projections, these finger-like projections that are coming through. So irregular borders, finger-like projections, which signify chronic scarring in that left common iliac vein. And this was a prime example of a patient who had post-thrombotic syndrome, who went undiagnosed for years, who had multiple superficial venous ablations. So what did we do? We went ahead and we did IVUS guided stenting in this patient. And as you can see on the final venogram, there is no longer any collateral branches. You don't see those squiggly lines anymore. and the patient has very nice outflow. So how did this patient do? Well, at 3 months, this is, you can see that she already started to have some nice scar tissue grow over the ulceration. And at this point, she was not a firm believer. She said, I've gotten to this point before, and I'm not there yet. You don't have my full confidence. But at 6 months, you can see here there was complete closure, and it never closed like that in 6 years. And so, unfortunately, since then, this patient has gone on, and she's done well, but she's no longer with us for other reasons. But we were able to close her ulceration, and she went on to have another 4 or 5 good years, and really appreciated it. And again, these are patients that we can really help in our community. So with that, and concluding, percutaneous endovenous stenting has emerged in the last decade as the method of choice to treat venous outflow obstruction due to chronic venous disease. And there's a plethora of publications out there that we'd be happy to share with you. Post-thrombotic syndrome should be assessed in patients that have a history of a DVT with chronic swelling. And again, this is certainly something that you can take out to your local community physician, referring physicians, podiatrists, and also hematologists. Stenting of the venous outflow obstruction in lower extremities, as we had shown, can be performed with low risk, long-term patency rate with a low rate of in-stent stenosis. But IVUS, or intravascular ultrasound, in my opinion, is critical in determining lesion presence, severity, and balloon stenting and sizing. Why do I say in my opinion? Because sadly, we are very scientific in CVR and CVM, but there still are, unfortunately, cases being done out in the United States and in the world where IVUS is not being utilized, and either stents are being misplaced or undersized or oversized. So again, IVUS is very important, and it's critical in determining and visualizing the vein prior to treating with potential stenting. So with that, I thank everybody for their attention, and I'd be happy to open it up to any questions or any comments to share with the group. Thank you.
Thank you, Vinay. So I have several comments to make based on your presentation. So one small correction, the video trial showed that there was 50% discordance between the IVUS and the venogram. In other words, venography missed 50% of the lesions, and it actually changed the treatment plan in those patients. And they showed that a area reduction of 60% on the receiver operator curve had the highest association with improvement in symptoms. You mentioned the Villalta score in the Cabin trial. So the big problem I have with the Villalta score is that it's not been validated, even though it's been used in multiple trials. So even in the Cabin trial, even though they showed a difference in the Villalta score, it did not show a difference in severe post-thrombotic syndrome. Only one patient, I think, in the trial actually developed an ulcer. And even in the ATTRACT trial, when you listen to Tony Camarata, he regrets making Villalta score the primary outcome measure. He actually thinks that the RVCSS is better. And in the new trial that they're doing right now, they're actually using RVCSS as the primary endpoint. So you also mentioned the SOX trial. You are correct. The SOX trial is the only one out there that tried to do a head-to-head comparison between patients who wore stockings and patients who didn't wear stockings. That trial has serious methodological problems in it. Most of the data that was obtained was done through surveys or through patient phone calls. And then it was just based on history. So, but the problem is it was done by Susan Kahn, who has a wonderful reputation. And it's the only trial out there that even tried to address the problem. So it's the one that's quoted the most often. And then finally, that last patient that you showed with the excellent clinical results after stenting, just remember, if you looked at the history that Vinay put up there, that patient had rheumatoid disease. So rheumatoid arthritis and all the autoimmune disorders actually can cause wounds that look like venous ulcers. These are called venous mimics. I've had patients with rheumatoid disease who had wonderful granulating wounds who stopped healing because they stopped taking their methotrexate or they stopped taking their medications, and then the wound wouldn't heal. So don't be fooled by patients who have a venous ulcer mimic like a rheumatoid arthritis. This particular patient obviously was treated correctly and it was a great pickup, but let's say that this wound stalled. The first thing that you should do is always ask them, are you still on your autoimmune meds? A lot of people can't afford it. They stop taking it because it makes them sick. So, and then finally, the last comment I'm going to make is Vinay focused on iliofemoral disease. there is some work right now being done in patients who've had femoral popliteal DVTs. Mark Garcia is a big advocate of people who have a recurrent ulcer that's non-healing because of the popliteal vein being affected. And what he's done is done balloon angioplasty of the femoral vein, not expecting that it's going to stay open, but hoping that it just opens up long enough for the venous hypertension to abate so that the wound can heal. I've had some anecdotal experience, not on myself, but from other colleagues like Tony Gasparis and Mark Meisner and people who have done it and said it does seem to work in those recalcitrant people in which you have nothing else to offer. So I'm not quite sure that's going to be the be all and the end all, but it's just another quiver in the arrow case, if you will, that you could have in the back. So there's work being done to see if you can improve post-thrombotic syndromes in the people with femoral popliteal disease, especially with the popliteal vein, where all of the outflow in the lower calf kind of merges in that one spot. So does anybody have a question for Vinay? This was a really good presentation, by the way. I hope you all appreciated it. Thank you, Vinay.
No, thank you, Dr. Pappas. I really appreciate all those very salient points, and I've definitely made corrections to that. Thank you. So going back to your comment about Villalta scores, Dr. Pappas. So with the data showing the way it is that something that we should continue to follow? Is that something that we should notate in our?
Yeah. You know, Vinay, that's a really interesting question. Like one of the talks I have to do for the New York Vein Symposium is to review the European, the Vascular Society recommendations. They actually give the Villalta score like a 1B recommendation. And I'm actually stunned at that because the Villalta score is overly sensitive and it's not very specific. I mean, one of the examples Tony Camerati gives is the patient who had a Villalta score of 4 but had no symptoms. And they enrolled that patient into the trial. So, you know, you're not going to get, after you lyse that patient, you're not going to get much better,
right?
You know, from a 4. So I think we need a validated scoring system for post-thrombotic syndrome. I think everyone's just got used to using it and no one's really admitting the faults of that score. So, I mean, right now it's kind of all that we've got and you kind of see it in all the written journal articles, but,
yeah, sure.
But I think it's overly sensitive. I'm not convinced it shows anything, and it's certainly not predictive for severe disease at all.
Okay, got it. So for now, we will continue to utilize it for more of an academic thing, but like I said, down the road, it may be something that's outdated or.
Yeah, I mean, listen, Dr. Camerata really feels that the RVCSS is probably a better measure. I mean, I'm not quite sure what the answer is. I'd like to see both of them done together head to head in these clinical trials and see which one seems to be more predictive. And my feeling is that the Villalta score finds too much disease that probably is not significant. It's overly sensitive.
Got it. Makes sense.
Anybody else have any questions for Vinay? All right, if not, I just, Dr. Nguyen has sent out several emails regarding the New York Vein Symposium. Remember, it is virtual this year. I would recommend if any of you want to find out what's the latest and greatest, it's usually one of the better educational symposia. Not that, you know, I'm trying to dump more things on people to do, but if you do have time, register. We've got CVR gets a discounted rate for it, and I think it's a good educational symposium. Plus, it doesn't require you to, you know, get on a plane and go someplace anyway. So, all right, everyone, listen, everybody have a wonderful weekend. Thank you again, Vinay. That was wonderful. And
thank you,
see you guys next week.